Hello, everyone, and welcome to BailaCura's new Spotlight series. We will be doing monthly posts and interviews talking about different types of cancer and how to prevent or treat them. And joining us today are Dr. Linda Van Ley and Dr. Ann Miller. We will be talking about cervical cancer today. So Linda and Ann, would you tell us a little bit about your work?
Sure. I'll start. I'm a general gynecologist. I work at Chapel Hill OBGYN. I've been in practice about 30 years, and I do just regular frontline OBGYN.
I'm Linda Van Ley. I'm the Distinguished Professor in the Department of OBGYN and the Division of GYN Oncology at UNC Chapel Hill School of Medicine. I have been here as long as Ann. I wasn't going to say 30 years, but I see a variety of patients, taking care of ovarian, endometrial, cervical cancer patients. I also run the clinical trials for our group, so know a little bit about treatment and new up and coming new treatments for all of the diseases relevant to clinical trials.
Yeah. Great, thank you. So to get started, could you tell us a little bit about how cancer develops and how it relates to cervical cancer? So what is cervical cancer and where does it show up?
Cervical cancer is detected early, or hopefully in a precancerous state, by a screening test called a Pap test. Most of us are familiar with it. It's been used in the U.S. for a number of years. So cervical cancer rates have dropped tremendously since the introduction of the Pap test. Linda can talk to you a little bit about how the tumor develops from the actual invasive cancer, but precancers are mostly related to what we know now is human papillomavirus infections and the aftermath of that.
So as Ann said, we could start with a whole lot of patients, but patients who have an infection with the HPV virus are really at higher risk, and there's some stimulus from the virus when it enters the cell that causes the cell to become precancerous than cancerous. So that's why the vaccination and screening for HPV now is so important.
So let's talk a little bit more about screening then. How do we screen for cervical cancer? Is our Pap the only type of test that we can do?
So the screening recommendations have changed. And they're continuing to evolve. So Pap tests alone were used for a number of years. HPV screening is now part of that screening modality, and there is some movement towards screening with HPV alone under certain circumstances, and may end up being the screening test of choice as we move forward. But right now it's Pap test, cytology, and co-testing with HPV is probably still sort of the standard for screening, done by your practitioner in the office, and an interval determined by your risk factors, which mostly has to do with your history of Paps that are abnormal or cervical cancer risk.
And what are some other risk factors for cervical cancer besides HPV? Are there other things that could contribute to the risk or the susceptibility of someone to cervical cancer?
Women who have immune compromised states are more at risk for cervical cancer, such as women infected with HIV or other primary cancers where they've been treated with chemotherapy or immunotherapy. They may have a higher risk of cervical cancer. But it seems like HPV is a necessary cofactor at some point in the patient's reproductive life to have begun this process of transformation to cancer.
Are there, I read, for example, that there are age differences or differences in the exposure to HPV depending on age or smoking status. Could those things contribute as well to?
Yes. Yeah. Thanks for asking about smoking. Yes, smoking does seem to be an independent risk factor for precancers and cancer of the cervix. And age, this is a more predominantly a younger woman's disease. There are older women who get cervical cancer, but it's much more common in a population in the age range of 30, 40, and 50.
Are there any specific ethnicities that are more susceptible to?
I didn't hear that. Sorry.
Race or ethnicity that could be more susceptible to cervical cancer?
Linda, I have not found that there's a significant difference other than other socioeconomic factors or lack of screening that we see invasive cervical cancers probably most often in this day and age in the patient population that has not had a recent screening test, PAP or HPV.
Yeah, it's hard to sort that out, right? Really, because I think if you look at the last 20 patients we've seen in our practice, and probably for you, Anne, they haven't had pap smears. So that is the most driving factor, regardless of ethnicity. So that's really pretty hard to sort out.
Yeah.
And are there different types of cervical cancer, and do they have different prognoses?
So there are several histologic types, and I just want to add that it's really important to not cross over into cervical cancer. Anne is usually talking about screening, and screening is to detect precancer. And the pap smear and HPV screening is the kind of the model for screening because it reflects easy and inexpensive way to screen and an opportunity to make the biggest difference. If you use a pap smear or HPV, you are looking for precancer. If you find a precancer, then you can intervene and absolutely cure that patient and stop the progression to cancer. So you're asking me about cancers. Gee, there are squamous cell is the most important and most prevalent, followed by adeno, and there's an adenosquamous, and there's a small cell. But I just want to emphasize and take this opportunity, do not go there. Once you get a cancer, even though we have effective treatment, recurrences happen and you can die anytime. So I think it's really important just to concentrate on what Anne said, the pap smear and HPV and being diligent about that.
Okay.
And I certainly spend a lot of time explaining to anxious patients who have an abnormal pap and have to have testing that, no, this is not cancer. It's really unlikely you develop it. My favorite line is, if you don't disappear from testing or screening, you will most likely not get a cancer. So it is important for, it's very distressing to have an abnormal test and to have to do further testing. But I really try to emphasize to patients that this is a precancerous state. Again, like Linda said, very easily curable if even needed to be treated. And most of the time we end up just needing to follow the patient a little more closely for a period of time.
So let me just take an opportunity, because I think that your group has a younger population. You're very healthy, dance oriented. And I really urge you to all get your HPV vaccine, right, Anne? Up to the age of 25, right? It's either single or double dose. But New England Journal of Medicine just came out with a paper a couple months ago, and it was amazing. They looked at the Swedish registry and they substantially decreased the risk of cancer by virtue of vaccination. So here is probably the first vaccination against cancer in the world. But the uptake in the United States, only 50%. If you go globally, they're dying for the vaccine, but they don't have enough and it's expensive. It's like a couple months of income. So I just want to take an opportunity for your readership and also for them to promote and be aware that almost the best thing they can do, don't you think, is to vaccinate?
Yes, absolutely. Because when I do a colposcopy or further evaluation, they ask me, well, doctor, what can I do? Most of the time it's like, well, not much except get vaccinated, don't smoke. There aren't many options for prevention, but the vaccine is a wonderful tool, and it's revolutionary in my mind. We may eliminate cervical cancer if the uptake is high enough.
Right. So, Felicia, along those lines, we don't have that much cervical cancer in this country. We have about 13 to 15,000 cases. If you look at that compared to breast cancer, about 250,000 cases, right? So, and if you look at those cervical cancer cases and there are like 5,000 to 6,000 deaths, we shouldn't have any at all, right? If everyone had gotten the vaccine, and it's going to take a while for the vaccine to take effect on the population, or their pap smear, we could have driven that number down to 10%, right? So I think the biggest message for our readership here, and I'm happy to talk about cancer and treatment, but I really don't want you to get to cancer. I want you to get your pap smear and get your vaccination. And then I usually tell Anne, the ideal age is, since I don't really give vaccination, is it 11 to 12 years old?
Correct. I think most of the vaccinations are offered in the pediatrics population, but if somebody did not get vaccinated, they're eligible to get vaccinated up to age 45 now, and it almost is completely covered by insurance.
Are we lucky? We're totally lucky. Like I said, they're begging for it in the third world, and there isn't even enough to go around. So
you think the low incidence compared to other types of cancers is exclusively due to the vaccine?
Right. But again, we could have zero, right? And in fact, a country that's doing a really good job is Australia. They are vaccinating, and they are screening, and they have driven their rate of cervical cancer down incredibly. So here's a country that has done it, and all we can do is look and say, if one country can do it, we can do it. So again, message to your very healthy dancer population, you need to do that.
Yes, thank you. So let's say for someone who doesn't have access to getting regular medical treatment, what would be the things that they need to look for? What could be some of the early symptoms of cervical cancer
Well, first of
or
all-
pre-cancer?
First of all, in North Carolina, you can get access, right? There's Planned Parenthood, there's health department, very reasonable. Do you have any other resources for, and do you know any county resources or anything for folks who don't have
The health
insurance?
department is a place that anybody can go. You know, one would hope that insurance coverage for screening is pretty good through, you know, most of the Affordable Care Act plans. So, or Medicaid coverage covers pap smear screening and HPV screening now in the appropriate population. But sort of universal preventive care coverage, it makes a big difference for patients. But there are still folks that lack access. That's true.
And I think even I'll just speak locally for Duke and UNC, they have financial assistance. So, you know, it is hard to overcome the system if you don't have insurance. It's just hard to be in that situation. But it's not impossible to get health care. As I mentioned, health department, Planned Parenthood for the PAP. And if you go to either of these institutions and apply and put in the papers to show that you're in need, you'll get the care. So I don't know if people know that, but we do it all the time.
Yeah. So
Telling us.
you were asking about some early symptoms of concern would be, especially if somebody has not had pap screening, bleeding after intercourse, in between period bleeding. Pelvic pain is a pretty rare initial kind of symptom, but usually it has something to do with an abnormal bleeding between periods. That would set off a little bit of a red flag, especially in a patient who's not been in for a while.
And vaginal discharge.
Yes, right. Thank you.
Yeah.
So would this be symptoms of early stages of the disease where it's still precancerous, for example?
You never know, right? Could be terrible.
Okay.
So, you know, I guess I would say if you have those symptoms and you go to see your primary and they didn't do a pelvic, someone needs to look in there.
Yes.
Right? You see that, right, Ann?
Yes,
Yeah.
we do. Right. Yeah. There's been a move toward, you know, diagnosing vaginal infection with self-swab. I'm all for, you know, self-care, but nothing replaces taking a direct look at the cervix on speculum exam to really get a good idea of does it look normal or not.
And so once you establish that there might be precancer, what are some of the strategies that you use to combat that?
She was asking about precancer.
Yeah. So I end up being mostly the person who treats the precancer and send it to Linda for difficult cases. But so if it's a significant precancer, we usually do a small cervical excision procedure that is conserves most of the anatomy, but is very effective, 90% effective as far as treatment that the patient never has a problem in. And it does give us a good specimen for evaluating to see is there anything in there that wasn't just precancer, which is a good idea. There are other options. We still use cryosurgery of the cervix in certain circumstances, but the LEAP, it's called LEAP, a loop electrosurgical excision procedure, is the current sort of most often used treatment for precancers of the cervix that need treatment. But most do not need treatment, which is great news, just need follow-up.
If, even though we have the tools to detect it early and to prevent it and to not get it, if it does progress to cervical cancer, what does that look like? And what are some of the treatments or interventions that we would need once we get to that?
So let me just mention 90% of cancers are squamous cancer, and those are detectable by PAP. There is a type of cancer called an adenocarcinoma, which is not necessarily detected by PAP. So I just want to make that clarification that we've been pushing screening, but some are not screenable. So should a patient have a diagnosis of cancer, so say she went to Ann's office and worked her up, saw a lesion, saw something growing on the cervix, took a biopsy, and it came back cancer, Ann would refer it to me. I'm a gynecologic oncologist. Patients with early cancers, which means confined to just the cervix. So we have criteria on how big and how wide are eligible for a radical hysterectomy. Regular hysterectomy is pretty straightforward. That's a kind of thing, procedure that's done for bleeding and fibroids. A radical hysterectomy is a bigger dissection. So we go wide and we go deep, and it has more complications. It could be the ureter, the conduit from the kidneys to the bladder could be injured. There could be denervation, shortening of the vagina, all sorts of things. Now, in the old days, we did that through minimally invasive surgery with little incisions, but these days we reverted back to an incision like a bikini incision, and that can be done. When you have a radical hysterectomy, which is for early stage 1, remember 1 through 4, 4 is the worst, disease, you can also maintain your ovaries if you want. Anything that's beyond the cervix, it's spread to the side walls or spread to other places, nodes, for example, is treated by radiation therapy and boosted with a tiny bit of chemotherapy. So there's really only, I always tell my cancer patients there are only 3 ways to treat cancer: surgery, radiation, chemotherapy. So surgery for early stage, radiation with chemotherapy for anything beyond.
And is there a timeline that it might follow where it is pre-cancer for X amount of time and then it becomes cancerous? Is that the same for everyone?
No, Linda has probably a better handle on time.
You can't tell. I think that we do rely on the continuum of low grade, moderate, or severe, or we call it level CIN, cervical intraepithelial neoplasia, which is a precancer, CIN 1, 2, and 3. And we do rely on that progression. For example, we hardly treat CIN 1s anymore. We follow those and hope they usually resolve. For a 2, we can follow them or we can treat. And for a 3, which is just the step next to getting cancer, we can follow certain patients, but we won't most likely treat them. In general, we'd say the progression from one level to another is pretty long. It's not like tomorrow. But when you meet a patient for the first time, you don't know how long they've had it. So I'd say no urgency, but work on it, treat it.
Right.
Are there any novel treatment therapies being researched, even prevention therapies besides the HPV vaccine?
For prevention, no, there are new screening approaches with looking at DNA methylation, kind of a little bit more complicated. The goal is to be able to have a screening tool that's more accurate, less expensive, and easier to do, right? So that's why they think the HPV screening is better, and even a step beyond that, DNA methylation or something else, always working on a better mousetrap. The PAP is very labor intensive. It's a slide in glass, needs to be transported, has to have pathologists or cytologists read it. So then you're relying on someone's eyeballs. I mean, it's rough and, very difficult for third world countries.
Right. That's what I was going to say. Access to trained technologists and laboratories in countries that don't have a wonderful healthcare system. HPV testing or some simple test that can just be sent to a central lab is much more doable for those countries, and then they can be referred to a specialist if necessary for further evaluation.
So besides urging our audience to get the HPV vaccine if they're in the group that qualifies for it and to visit their doctor regularly, is there anything else you would like to tell us?
One of the HPV risk factors is number of partners. So that's always something that I bring up. If you really want to, screen your partners carefully and choose wisely, and that is something that can help. And that that's an interesting conversation. But as a gynecologist, we have that every day. But that is something to think about. If you want to really protect yourself, be selective.
Good point. Good point.
Well, thank you. This was very informative. I certainly learned a lot, and I hope it's useful for our audience. And we will do this again next month. We will talk about a different type of cancer. Thank you, Anne and Linda. If you are interested in learning about BailaCura, please go to our website. It's www.bailacura.org, so you can learn more about our mission and help support it. Thank you so much, and we will see you again soon.
Thank you for inviting us.
Yes, thank you.